decreased PO intake, but no vaginal bleeding. Additional history was obtained at this time, and the patient reported having been on IV iron for iron deficiency anemia by an outside hematologist, but her last dose was July of 2023. And then she was receiving monthly IVIG for a mixed autoimmune deficiency that she reports was due to COVID. And her last dose was just a few weeks after her initial surgery. A CTA was done due to her downtrending hemoglobin to rule out any active bleeding, but that was negative. There was no pelvic collection or abscess and no active bleeding that was seen. Inpatient, when she arrived, her hemoglobin was again 6.4. She received a unit of blood that did not respond. Her hemoglobin was 6.1 afterwards. And a platelets had downtrended from 100 to 75.
Devika.
Mhm.
So we only have 4 minutes, so you can stop giving us the day by day and just tell us the final answer, what happened wrong. You don't have to go day by day anymore.
Okay. I'm almost done. So she was admitted to the hospital for workup and then discharged. And then she followed up with hematology, but has not yet followed up with gynec. Okay, that's it.
All right. So what happened here, Devika? What there's got to be some backstory or some underlying story. What just sum it up for us. What happened here?
So I think in her case, there was a few different reasons why she may have had two cuff dehiscences. I think um, she did have some underlying possible autoimmune disorder. She's still getting workup for her hepatosplenomegaly with a PET scan and possibly biopsy by hematology to rule out a lymphoproliferative disorder. So I think that might have been contributing. But at the same time, I think the patient also wasn't strictly adhering to Rex or our Rex for pelvic rest, or she was continuing to lift her children. So she's continuing to put intra-abdominal pressure. So I think that's probably a few things that were contributing to her. And I think overall she's
By
very poor
by
quality.
by saying that she wasn't following our recommendations for pelvic rest, are you saying that she was forced into having sex?
No, I mean like she was putting intra-abdominal pressure. So she was lifting when she shouldn't have been lifting. She said she was not having sex.
Are there any other questions?
I have one, Steve Goldberg. How often are we seeing cuff dehiscences after the robotic surgeries?
So it's actually very rare for the cuff dehiscences. There has been some studies that possibly after a TLH or robotic assisted TLH, the risk of a cuff dehiscence is slightly greater than after an open or a vaginal hysterectomy, possibly from the electrocautery used at the cuff or the continuous suturing of the cuff. But the studies are pretty scant just because it's not that common for this to happen.
All right. Well, thank you, Devika. Thank you very much for that excellent job. So now it's time for us to transition into grand rounds. In a moment, I'm going to ask Dr. Stevenson to introduce our grand round speaker. But in the meantime, just some announcements about attendance. Michelle and Beth and I are always on the lookout for the names of the people who are in our M&M and grand rounds, and we like it very much when we can read your full name, both first and last, um, just so that we can make sure there's no one in the meeting that's not supposed to be. For example, this morning when I logged on very early at 7:20, there was already an 11-digit number in attendance. And so I sent a chat to that person to tell me their name, and they didn't respond. And then I audio asked them to identify themselves, and they didn't identify themselves. And so, of course, I just kicked them out as the host. So number one, if you are signing in with an unusual phone number, you can always email or text or just say your name And Michelle and I and Beth are happy to keep you in the meeting. And secondly, if that person complains to you later on today that they got kicked out, please explain to them why I had to maintain the safety of our meeting. And so with that, Dr. Stevenson, are you ready to introduce our speaker?
I am. So it is my pleasure to introduce our newest UN oncology partner, Dr. Patankar. We are thrilled that she's here. A little bit about Dr. Patankar. She did her undergrad at Georgetown. She did her internship and residency at Columbia University with our one and only former Dr. Buckley. She did her fellowship at the University of Pennsylvania and then was in practice and an assistant professor at the New York Medical College up at Westchester. She's a native New Jerseyan. I don't even know if you know if that's how you say it because I'm not from New Jersey. But so she was able to come back and join us, and we are so excited that she's here. She's very passionate about education and has extensive awards and experience in developing programs for our trainees. And some of her research interests are in palliative care. Today, she's going to be talking to us about the evolution of treatment for cervical cancer. I'm excited to hear her thoughts. Dr. Patankar?
Good morning. Thank you so much for having me today. So I'm going to spend, I think my video is off, I believe, and I'm trying to turn it on. Dr. Ebert, do you know how I?
So it would be the orange menu bar at 12 o'clock on the screen you're sharing.
Okay.
But if you had to present without your camera, it wouldn't be the end of the world.
Okay.
We see your slide
Okay.
perfectly.
Okay, perfect. All right, thank you. So thank you so much for having me today, and thank you, Ruth, for this wonderful introduction. So I'm going to spend the next 45 minutes or so talking about cervical cancer, with the focus of the talk being the evolution of treatment for cervical cancer. There have been a lot of really exciting things happening in the field. So I do not have any disclosures. So let's begin this talk with some important history. The 1880s and 1890s was an era of rapid surgical developments. In 1878, abdominal hysterectomy was described for removal of a cancerous uterus by a German gynecologist. Then, on November 16, 1898, Dr. Ernst Wertheim, an Australian gynecologist, performed the first abdominal radical hysterectomy for a patient with cervical cancer. And this here is a famous picture of Dr. Wertheim at the operating table. Now, the procedure was morbid with a significant death rate. Technical improvements in the procedure over the next few decades resulted in less morbidity and increased survival. Even today, radical hysterectomy remains the mainstay of treatment for early-stage cervical cancer. So cervical cancer existed, and physicians were performing radical procedures to treat the disease in the 1800s. But some scientists questioned whether this disease could be prevented. So no talk on cervical cancer is complete without discussing George Papanikolaou. So George Papanikolaou was born on a small island in Greece. He married Mary, who was from a famous military family. Papanikolaou became interested in career opportunities in the United States and decided to emigrate, arriving in New York in 1913. Neither spoke English and had in hand roughly only $250. Now, incredibly, Papanikolaou was able to get a job at NYU's pathology department and Cornell University's anatomy department, where his wife joined him. In the 1920s, George Papanikolaou began to focus on the cytopathology of the human reproductive system. His wife, Mary, was a crucial partner in his research. She worked in the same lab as an unpaid technician and provided a vaginal sample for research every day for 21 years. In 1920, and this is a picture here of George Papanikolaou with his wife, Mary. In 1920, he realized that he could tell the difference between normal and malignant cells of the cervix by viewing smears on a slide under a microscope. So in 1928, Papanicolaou told an incredulous audience of physicians about the non-invasive technique of gathering cell debris from the vaginal tract and then smearing it on a glass slide for microscopic examination to identify cervical cancer. So this is what we all still know today as the Pap smear. But this simple low-cost method was met with a lot of skepticism. Then, in 1943, Dr. Herbert Trout and George Papanicolaou published their landmark book, Diagnosis of Uterine Cancer by the Vaginal Smear. After this publication, the Pap smear quickly became the gold standard in screening for cervical cancer. Now, Dr. Oral Babes, a Romanian physician, made similar discoveries in the 1920s. He used a platinum loop to collect cells from a woman's cervix to detect cancer. However, the credit still goes to Papanicolaou. Babes' technique was substantially different and would never have lent itself to mass screening without significant modification. So now during this time, other scientists were trying to figure out what actually causes cancer. So the search for a germ that could cause cancer began in the late 19th century. On February 14, 1912, the New York Times reported the first success in the hunt. An article headlined, "Clue to Parasite as Cause of Cancer," described an experiment with chickens carried out by Dr. Peyton Roos, who you can see here. And Dr. Peyton Roos is now considered the founding father of cancer virology. So let's talk a little bit about this experiment. So in 1909, a poultry farmer noticed a lump on the breast of one of his chickens. Concerned that she may sicken others in her flock, he asked Dr. Rouse for help. A biopsy of the lump found it to be a sarcoma. Dr. Roos cut off a piece of the tumor, ground it up, and passed it through a filter to remove all of the cells. Then he injected the cell-free liquid into other chickens who developed tumors within a few weeks. So this was the first hint that cancer or a tumor could be transmitted by a microscopic, non-cellular agent, what we now call a virus. So spurred by Dr. Rouse's discovery, scientists would, for the next 75 years, try to prove that human cancer too could be caused by a virus. So the potential link between a viral infection and cervical cancer was noticed in the 1950s by scientists searching for clues to things that may trigger cervical cancer. Scientists had made a surprising observation. Cervical cancer was more common among women who started having sex at a younger age or who had multiple sexual partners. HSV2 was believed to be a contributor, but there was really no proof at the time. So this piqued the interest of German virologist Dr. Harald Zerhausen, who you see here. He had read reports from doctors about women with genital warts also developing cervical cancer. He was also aware of the work of Richard Schoep from the 1930s, showing that infection with a type of papillomavirus could cause warts and cancers in rabbits. So Zerhausen began his quest by looking for viruses in human genital warts, leading to the discovery of a new type of papillomavirus, which he called HPV-6. But to his disappointment, his team couldn't find HPV-6 in any cervical cancer samples. His team continued their search and in the 1980s discovered HPV-16 and HPV-18 were detected in majority of cervical cancers. It became clear that infection with these two types of HPV was closely linked to cervical cancer. And this discovery eventually won Dr. Harald Zerhausen a Nobel Prize. So over the next decade, more evidence began to pour in, linking more types of the virus to cervical cancer. In 1995, the International Biological Study on Cervical Cancer Group was set up to look at the bigger picture. Using samples from 22 countries, they found virtually all cervical cancer samples, 99.7%, contained the HPV virus, and this figure was consistent across the globe. All right, so enough about history. Let's move on to discussing some specifics about cervical cancer. So cervical cancer is the fourth most common cancer in women globally. It ranks after breast, colorectal, and lung cancer. In 2020, there were approximately 600,000 new cases and 340,000 deaths. Cervical cancer is the third most common GYN cancer in the United States. In 2022, there were about 14,000 new cases and 4,200 deaths. The highest rates of cervical cancer incidence and mortality are in the low and middle income countries. This reflects major inequities driven by lack of access to HPV vaccination, cervical cancer screening, treatment services, and social and economic determinants. Cervical cancer is the leading cause of cancer-related death in Africa. So what are the histologic types of cervical cancer? So there are two major histologic types. The most common is squamous cell carcinoma, which accounts for 65 to 85% of cases. Its precursor is squamous cell carcinoma in situ. Adenocarcinoma is the second most common. The number of cases of adenocarcinoma has actually increased over time. It accounts for 20 to 25% of cases. Then you have the less common histologies, which include adenosquamous carcinoma, mucinous adenocarcinoma, glassy cell carcinoma, and neuroendocrine tumors, just to name a few. So what are some of the risk factors? Infection with HPV is really the key to development of cervical cancer. Other risk factors include early onset of sexual activity, multiple sexual partners, history of sexually transmitted infections, history of vulvar intraepithelial neoplasia or vulvar cancer, immunosuppression, and cigarette smoking. So how do you diagnose cervical cancer? The diagnosis of cervical cancer is made by performing a biopsy. It is safe to perform these biopsies in the office setting. Just keep Monsal's silver nitrite and some scopettes on hand, as sometimes these masses can bleed. Do not perform a pap smear when you see a cervical mass. With cytology, the false negative rate for squamous cell carcinoma is 20%, and the rate is much higher for adenocarcinoma at 40%. So really, the key takeaway is this. If you see a mass, perform a biopsy. Do not defer biopsy until the patient sees a GYN oncologist, because this will delay the diagnosis and then most importantly, the patient's treatment. So how do we work up a patient with cervical cancer? So staging is now clinical and radiological. In the past, only clinical staging was utilized. But the most critical component of staging still is a thorough pelvic examination, including a rectovaginal exam. So this can inform you whether there is invasion into the rectum and also whether there is any parametrial involvement. A PET-CT scan is often used to aid in staging and evaluate for metastatic disease. A PET scan is considered the best modality to assess for nodal disease. An MRI can also be helpful to assess local disease extent. So here you can see some MRI images. You see here in the upper image, there is a cervical tumor that is invading into the upper vagina and into the bladder. Down here, you can see a posterior cervical mass, and the tumor is also extending down into the upper vagina. And here you see this bright color here. That's just vaginal gel to help distend the vagina, and then you can better delineate the tumor. So MRI of the pelvis can inform you of the size of the cervical mass and whether there is parametrial involvement or invasion of the bladder or rectum. The cervical cancer staging system has changed in 2018. So let me just highlight the three major changes. First, width was removed in early stage disease. Second, there was a change in 1B disease. In the past, we only had 1B1 and 1B2. 1B1 was tumor size less than or equal to 4 centimeters, and 1B2 was tumor size greater than 4 centimeters. Now, we have three subsets of 1B disease. 1B1 is considered tumor size less than or equal to 2 centimeters. 1B2 is tumor size greater than 2 centimeters, but less than or equal to 4 centimeters. And 1B3 is tumor size greater than 4 centimeters. And lastly, stage 3C1 and 3C2 were added. 3C1 is pelvic lymph node involvement, and 3C2 is para-aortic lymph node involvement. A PET-CT scan is used to make this determination. So now let's begin the discussion about treatment of cervical cancer. I'm going to highlight some of the exciting new advances in the field, but I won't be discussing the treatment of microinvasive disease during this talk. So let's start with the treatment of early stage disease. So the standard treatment for patients with early stage or stage 1A2 to 1B2 cervical cancer is a radical hysterectomy with pelvic lymph node dissection. So as you can see from this chart on the right-hand side, a radical hysterectomy is a more extensive procedure than a simple hysterectomy and includes the removal of the uterus, cervix, upper vagina, and the tissue around the cervix. During a simple hysterectomy, only the uterus and cervix are removed. For patients with cervical cancer, a pelvic lymph node dissection is also an integral part of surgery to exclude the presence of lymph node metastases. Because radical hysterectomy is a more complex surgery, it requires more extensive surgical training and is potentially associated with more acute and long-term side effects, such as bleeding, bladder and ureteral injury, bladder and bowel dysfunction, as well as potential impacts on quality of life and sexual health. Now, in treating women with early stage disease, two major questions have arisen. The first question is, should a radical hysterectomy be performed open or via a minimally invasive approach? And secondly, can we be less radical? Do all patients with stage 1A2 to 1B2 cervical cancer need a radical hysterectomy? So let's address the open versus MIS question first. With the advent of minimally invasive surgery, GYN oncologists began performing radical hysterectomies laparoscopically and robotically. This is because there are many advantages to minimally invasive surgery. Retrospective studies involving patients with early stage cervical cancer have shown that laparoscopic radical hysterectomy is associated with less intraoperative blood loss, a shorter length of stay, lower risk of postoperative complications, and fewer infections. There are also many advantages of minimally invasive surgery for surgeons, particularly with robotics. So the robot allows 3D vision and depth perception. It is ergonomic. There is camera stabilization, tremor filtration, wristed instrumentation that allows ease of suturing, more elegant and precise dissection, and better visualization due to magnification. So we were using this new technology, but people began asking, is minimally invasive surgery actually a safe modality in patients with cervical cancer? So there was a paucity of adequately powered prospective randomized trials evaluating survival outcomes until this seminal study that was published in the New England Journal of Medicine in 2018. The study is titled Minimally Invasive versus Abdominal Radical Hysterectomy for Cervical Cancer, and it was a practice-changing study and definitely one worth a discussion. So this was a prospective randomized phase 3 non-inferiority trial. It included patients with stage 1A1 disease with lymphovascular space invasion, 1A2 and 1B1 disease, which was a tumor size less than 4 centimeters. They used the old staging system, the one before 2018. Patients with squamous adenocarcinoma or adenosquamous cervical cancer were included and then randomized to either total abdominal radical hysterectomy or total laparoscopic or robotic-assisted radical hysterectomy. 312 patients were randomized to the open abdominal approach, and 319 patients were randomized to the minimally invasive modality. The primary outcome was to compare disease-free survival between the two groups, and the secondary outcomes were overall survival and patterns of recurrence. Here you can see the baseline characteristics of the patients. The treatment groups were balanced with respect to baseline characteristics. Most patients had squamous cell carcinoma, and the majority of patients, almost 92%, had stage 1B1 disease. Now, of the patients who were assigned to minimally invasive surgery, 85% underwent laparoscopic surgery, and 15% underwent robotic surgery. The rates of postoperative adjuvant chemotherapy or radiation were similar in the two groups. So here are the key findings. The study found that minimally invasive radical hysterectomy in a patient with cervical cancer was associated with a lower rate of disease-free survival. Patients who underwent minimally invasive radical hysterectomy had 3.74 times the risk of disease recurrence or death from cervical cancer. The study also found that minimally invasive radical hysterectomy for cervical cancer was associated with worse overall survival, a higher rate of death from cervical cancer, and higher rate of local regional recurrence. Now, it is important to keep in mind that there have been many criticisms of this study. So the use of a transcervical uterine manipulator and lack of proper tumor containment could have led to possible peritoneal contamination. There was also lack of proper preoperative imaging. It is also really important to note that the results of the trial cannot be generalized to patients with low-risk early-stage cervical cancer. So these are patients with tumor size less than 2 centimeters, negative lymphovascular space invasion, negative nodes, and depth of invasion less than 10 millimeters. And this is because the trial was just not powered to evaluate oncologic outcomes in that context. Now, many studies since this publication have evaluated various patient and surgical factors to try and determine if MIS truly results in worse survival for patients with cervical cancer, with mixed results. At this time, there is no high-quality data available. Now, there is an ongoing ROC or GOG 3042 study, which is a prospective randomized non-inferiority trial comparing robotic versus open radical hysterectomy for patients with early-stage cervical cancer. Their hypothesis is that robotically assisted radical hysterectomy with proper tumor containment prior to colpotomy is non-inferior to abdominal hysterectomy with respect to disease-free survival. Here you can see the inclusion criteria. Now, as you can see, they really took into consideration the major criticisms of the prior study. Unlike the prior study, they required all patients to have a preoperative MRI to confirm tumor size is less than 4 centimeters. Importantly, surgeons were not allowed to use a transcervical manipulator. And lastly, they required a proper tumor containment system. So this study will be very informative, but until we have results from this study, open radical hysterectomy remains the mode of choice for women with non-low risk early stage cervical cancer. Now, the second question we need to answer is whether less radical surgery can be performed for certain patients with early stage cervical cancer. So in the last 2 decades, there has been a trend towards less radical surgery in patients with low-risk cervical cancer because of the morbidity that's associated with radical hysterectomy. Retrospective data have shown that in carefully selected patients, the risk of paramutual involvement is less than 1%. It also suggests that less radical surgery may be safe and less morbid. Now, we do have prospective data that supports less radical surgery. And there are 4 studies: GOG 278, a Brazilian study, SHAPE, and CONSERVE. GOG 278 assessed the impact of non-radical surgery, so simple hysterectomy or cone biopsy, both with lymphadenectomy, on functional outcomes of lymphedema, bladder, bowel, and sexual function. Their secondary outcomes were recurrence and survival rates. The findings from this study suggest that non-radical surgery appears safe, but long-term follow-up is needed. And the results of the study were actually just presented at SGO earlier this week. For the sake of our talk, I will focus on the SHAPE and the CONSERVE studies. So the SHAPE study, simple versus radical hysterectomy in women with low-risk cervical cancer, was just published in the New England Journal of Medicine in February 2024. So this was a multi-center randomized non-inferiority trial comparing radical hysterectomy with simple hysterectomy, including lymph node assessment in patients with low-risk cervical cancer. 700 patients were included. Patients were eligible for trial if they had squamous adenocarcinoma or adenosquamous carcinoma. FIGO stage 1A2 or 1B1 disease was included, and this was the old staging system. Any grade was eligible, but tumor size had to be less than or equal to 2 centimeters. There needed to be less than 50% stromal invasion based on an MRI or invasion less than 10 millimeters on LEAP or cone. Preoperative imaging needed to confirm that the patient had no evidence of metastatic disease. And their primary endpoint was cervical cancer recurrence in the pelvic area at 3 years. So here are the key findings. 92% of patients in this study had 1B1 disease, but tumor size had to be less than or equal to 2 centimeters. 62% of patients had squamous cell carcinoma, and 50% of patients underwent laparoscopic surgery, 25% robotic, and 23% abdominal. They found that simple hysterectomy was non-inferior to radical hysterectomy with respect to the 3-year incidence of pelvic recurrence. Extrapelvic relapse-free survival and overall survival were also comparable. Patients in the simple hysterectomy group experienced fewer intraoperative urologic surgical complications and fewer immediate and long-term bladder problems. Body image, pain, and level of sexual activity were also more favorable in the group that underwent simple hysterectomy. Now, the CONSERVE study was a prospective single-arm, multi-center study. Their objective was to evaluate the feasibility of conservative surgery in women with early-stage, low-risk cervical cancer. Low-risk disease was defined as FIGO stage 1A2 to 1B1, squamous cell carcinoma any grade or adenocarcinoma grade 1, grade 2, tumor size less than or equal to 2 centimeters, no LVSI, negative imaging for metastatic disease, and negative conization margins, and 1 repeat cone was permitted. 100 patients were enrolled, and there were 3 groups. So patients who desired fertility preservation underwent a cone biopsy. If all inclusion criteria were met, they then underwent pelvic lymph node dissection, and there were 44 patients in this group. The second group is patients who did not desire fertility preservation. They underwent a cone biopsy, and if all inclusion criteria were met, they underwent a simple hysterectomy with pelvic lymph node dissection, and there were 40 patients in this group. The last group was patients who did not desire fertility and were undergoing a simple hysterectomy for other reasons. They had an unexpected postoperative diagnosis of cervical cancer. If all inclusion criteria were met, they underwent pelvic lymph node dissection only, and that was 16 patients. So the median age at surgery was 38. Majority of the patients had stage 1B1 disease. Residual disease in the post-conization hysterectomy was noted in 1 out of 40 patients, which is considered an immediate failure rate of 2.5%, and that's considered low. With a median follow-up of 3 years, 3 patients developed recurrent disease within 2 years of surgery, which is a cumulative incidence rate of 3.5%, also considered low. So this data shows that selected patients with early-stage low-risk cervical carcinoma may be offered conservative surgery, and this criteria is now incorporated into the NCCN guidelines. Okay, so let's now move on to discuss the treatment of locally advanced cervical cancer, which is considered stage 1B3 to 4A disease. Now, up until the 1990s, radiation therapy alone was the treatment of choice for patients with locally advanced cervical cancer. Radiation therapy consisted of external beam radiation therapy, which treats the gross disease, primary tumor, lymph nodes, parametria, uterosacral ligaments, and at least 3 centimeters of the vagina from gross disease. Careful planning is required to protect vital organs. Radiation therapy also includes brachytherapy, generally utilizing an intracavitary approach to boost treatment to the gross tumor and also improve disease control as well as survival. So a cervical sleeve is placed through the cervix into the uterus, generally in the operating room. Then the tandem, which you see here, is placed into the cervical sleeve, and then these ovoids sit on either side of the cervix, and that part is done as an outpatient. So historically, low-dose rate brachytherapy was commonly employed using the cesium-137 isotope. Patients were hospitalized after placement for 24 to 72 hours to allow delivery of LDR treatments. It also required prolonged immobilization and administration of agents to slow bowel movements due to immobilization. There were also concerns related to radiation exposure to healthcare workers because remote afterloading technology was not available. Now we give high-dose rate brachytherapy using iridium-192. So it has a lot of advantages compared to low-dose rate brachytherapy. The treatment is short, about 30 minutes, and it is given outpatient. Patients are much more comfortable and do not require prolonged immobilization, and it is also much safer for the healthcare workers. Now, over time, questions arose about ways to improve survival in patients with locally advanced cervical cancer. People began questioning whether we should give chemotherapy concurrently with radiation therapy, as it may help radiation become more effective. So there were 5 historical trials that assessed the benefit of chemotherapy sensitization in patients with locally advanced cervical cancer. In all of these studies, patients were randomized to receive either radiation therapy alone or chemotherapy that was given together with radiation. I won't go into the details of which agents they used right now, but all of these trials demonstrated that the addition of chemotherapy to radiation improved progression-free as well as overall survival. And this led to a National Cancer Institute alert in 1999, after which chemotherapy with radiation, also known as concurrent chemoradiation, became the standard of care for patients with locally advanced cervical cancer. So despite the improvement in survival that was noted with concurrent chemoradiation, we continue to seek other therapies that can further improve outcomes. So there have been many exciting advancements in cancer therapy, including the utilization of immunotherapeutic agents. So let's take a minute to discuss how immunotherapy works. So the immune system is the body's natural defense against disease. And when functioning properly, T cells are activated and attack the tumor cells. Now, cancer cells interact with the programmed cell death pathway. PD-1 and PD-L1 are proteins. PD-1 is located on the T cell, and PD-L1 and PD-L2 is located on normal cells and tumor cells. PD-L1 and PD-L2 ligands on the tumor cells bind to the PD-1 receptor on the T cells to inactivate them. It is basically the cancer's way of telling the T cell to leave it alone. Cancer cells use this pathway to essentially suppress the immune system so they can continue to grow and metastasize. So pembrolizumab, also known as Keytruda, has been widely studied in the treatment of cervical cancer. Cervical cancer cells can be tested to see whether they're PD-L1 positive or not. Now, pembrolizumab, or Keytruda, binds to the PD-1 receptor on the T cell and blocks its interaction with the PD-L1 and PD-L2 located on the tumor. Because of this, the cervical cancer cells cannot inactivate the T cells, and the T cells can fight. Now, pembrolizumab does have many side effects, as you can imagine, because essentially the immune system is getting activated, and this can have an impact on both the cancer cells and healthy cells. The side effects include immune-mediated pneumonitis, hepatitis, endocrinopathies, nephritis, colitis, and skin reactions, and so these patients do need to be monitored very closely. Now, pembrolizumab has shown efficacy in patients with advanced cervical cancer, and we will discuss some of this important data soon. Since it has shown efficacy in advanced cervical cancer, the question then arose, can we use pembrolizumab in patients with locally advanced cervical cancer? Can we add immunotherapy to concurrent chemoradiation to improve outcomes for patients with locally advanced cervical cancer? So the Keynote A18 study was just presented at ASCO in June of 2023. So this is a phase 3 randomized double-blind trial that enrolled patients with high-risk locally advanced cervical cancer who have stage 1B2 to 2B disease. So this was the old staging with lymph nodes that are positive. So these are the patients who would now actually be considered stage 3. And it also included patients with stage 3 to 4A disease, regardless of lymph node positive disease. Patients needed to have histologically confirmed squamous cell carcinoma, adenocarcinoma, or adenosquamous carcinoma of the cervix, and no prior definitive surgery, radiation, systemic therapy, or immunotherapy was allowed. Patients were randomized 1-to-1 to receive pembrolizumab plus concurrent chemoradiation, followed by pembrolizumab maintenance therapy every 6 weeks for an additional 15 cycles, or placebo plus concurrent chemoradiation followed by placebo maintenance. The primary endpoints were progression-free and overall survival. Now, this study is awaiting publication, but they found that the addition of pembrolizumab to concurrent chemoradiation improved progression-free survival. The overall survival data is not yet mature, but there was also a favorable trend. And on January 12, 2024, the FDA approved pembrolizumab with chemoradiation for patients with newly diagnosed high-risk locally advanced cervical cancer. So unfortunately, many patients with locally advanced cervical cancer relapse and die of metastatic disease. The Outback study was initiated to see whether additional treatment with systemic chemotherapy, 4 cycles of carboplatin and paclitaxel after chemoradiation, will improve survival. And unfortunately, this was a negative study. It showed that adjuvant chemotherapy with carboplatin and paclitaxel after standard chemoradiation increased toxicity and did not improve overall survival, as you can see here, and it also did not improve progression-free survival. So, if chemo after chemoradiation does not improve survival like Outback showed, what if we tried some induction or neoadjuvant chemotherapy before chemoradiation? Will this possibly improve survival? So the GCIG Interlace trial sought to answer this question. The findings were very recently presented at ESMO in October of 2023. So this study included 500 women from 32 centers in 5 countries. They were randomized 1-to-1 to receive either chemoradiation alone or induction chemotherapy with carboplatin and paclitaxel that was then followed by chemoradiation. Their primary endpoints were progression-free and overall survival. Majority of the patients in the study had squamous cell carcinoma. 77% had stage 2 disease, and more than half, almost 60%, had no metastatic disease to the lymph nodes. So this figure shows the progression-free survival. As you can see, progression-free survival was significantly improved for patients who received induction chemotherapy with chemoradiation. The overall survival was also significantly improved. As expected, grade 3 or worse adverse events were more common in patients who received induction chemotherapy. Now, while the results are promising, the problem with the study is that majority of the patients in this study were not high risk. Most patients had stage 2 disease and did not have lymph node metastases. These are the patients who are considered highest risk for relapse. Also, while efforts were made to enroll from diverse healthcare settings over the 10-year completion period, the majority of the patients, 76%, were recruited from the UK, so these results may not be well generalized. So now that we have covered recent advances in the treatment of locally advanced cervical cancer, let's move on to what's new for patients with advanced cervical cancer. Advanced cervical cancer is not considered to be curable, and it has a very poor prognosis. Now, until recently, the standard of care for patients with advanced cervical cancer has been chemotherapy with bevacizumab. However, in 2021, Keynote 826 was published in the New England Journal of Medicine, and it was really a practice-changing study. So this phase 3 multinational double-blind randomized trial examined whether adding pembrolizumab to platinum-based chemotherapy with or without bevacizumab would improve outcomes in patients with persistent, recurrent, or metastatic cervical cancer. So in this study, 617 patients with cervical cancer who had not previously received systemic chemotherapy were randomly assigned to receive pembrolizumab or placebo every 3 weeks up to 35 cycles with platinum-based chemotherapy with or without bevacizumab. The primary endpoints were progression-free and overall survival. So the study found that progression-free and overall survival were significantly longer in the pembrolizumab group than in the placebo group, both in patients with a PD-L1 combined score greater than or equal to 1 and in those with a PD-L1 combined score greater than or equal to 10. Now, further study is required to understand whether pembrolizumab has a role in treating patients with low PD-L1 expression scores less than 1. Only 11% of patients in the study had PD-L1 scores less than 1 in each group. The duration of response was also longer in the pembrolizumab group than in the placebo group. So on October 13th, 2021, the FDA approved pembrolizumab in combination with chemotherapy with or without bevacizumab for patients with persistent, recurrent, or metastatic cervical cancer whose tumors express PD-L1. Let's now turn our attention to treatment advances in the recurrent setting. Poor prognosis and high mortality are hallmarks of recurrent cervical cancer, especially in women who have already received systemic therapy. In 2021, the FDA granted accelerated approval to an exciting new agent known as Tivdak. So Tivdak, also known as tisotumab vedotin TFTV, is the first and only antibody drug conjugate, or ADC, for the treatment of adult patients with recurrent or metastatic cervical cancer with disease progression on or after chemotherapy. So what is Tivdak? Tivdak was designed with 3 components. The first component is a novel, fully human monoclonal antibody directed against the cell surface protein tissue factor. Tissue factor is prevalent on cervical cancer cells and is also present on some epithelial cells. Tissue factor expression is associated with cancer pathophysiology and cancer development. The second component is a cytotoxic agent, MMAE. This is a potent microtubule disruptor. And the third is a protease cleavable linker that attaches the cytotoxic agent to this monoclonal antibody. Now, each component plays a crucial role in the mechanism of action of Tivdak. The anti-cancer activity of Tivdak is a result of Tivdak binding to tissue factor expressing cells. Then the Tivdak tissue factor complex is internalized and trafficked to lysosomes. MMAE is then released from the antibody via proteolytic cleavage. MMAE disrupts this microtubule network of actively dividing cells, and it is this disruption that leads to cell cycle arrest and apoptosis. So Tivdak is indicated for patients with a diagnosis of recurrent or metastatic cervical cancer who had disease progression on or after doublet chemotherapy with or without bevacizumab and pembrolizumab. In the Phase 3 Innovative 301 study, patients were randomly assigned 1-to-1 to IV tisotumab vedotin every 3 weeks or investigator's choice chemotherapy. 502 patients were randomized, and the study found that Tivdak led to a 30% reduction in the risk of death versus investigator's choice of chemo. There was also a 33% reduction in the risk of progression. And this follow-up data was just presented at SGO this week. Now, Tivdak is truly one of the exciting new advancements in our field, but it does have some notable side effects. Tivdak causes changes in the corneal epithelium and conjunctiva, resulting in changes in vision, including severe vision loss and corneal ulceration. Patients must get an ophthalmic exam at baseline and prior to each dose. It requires diligent eye care, and patients have to use corticosteroid, vasoconstrictor, as well as lubricating eye drops with specific administration instructions. Patients can also experience fatigue, nausea, peripheral neuropathy, and hemorrhage. Now, we have spent so much time discussing treatment for cervical cancer, but let's not forget that cervical cancer is preventable. I just cannot give a talk on cervical cancer without discussing the HPV vaccination. So knowledge that persistent HPV infection is the main cause of cervical cancer has resulted in the development of prophylactic vaccines to prevent infection. There are 3 vaccines, and all of these are prophylactic, not therapeutic. There is a lot of evidence to support the use of these vaccinations, which is a topic for another time. The bivalent vaccine targets HPV 16 and 18. The quadrivalent vaccine targeted HPV 6, 11, 16, and 18. Currently, the only available vaccine in the US is the 9-valent or Gardasil 9, which targets the 4 HPVs from the quadrivalent vaccine, as well as HPV 31, 33, 45, 52, and 58. And the efficacy rate for Gardasil 9 is 97%. The vaccine can be administered starting at age 9 and up to the age of 45. We frequently also vaccinate patients older than 45 who have cervical dysplasia or new sexual partners. Now, the wonderful thing is that if the series is interrupted for any length of time, it can be resumed without restarting the series. There is limited information about its safety during pregnancy, and therefore it is not administered during pregnancy. Patients frequently ask if there is any utility to getting the vaccine if they already have HPV. And the answer is absolutely yes, because the vaccine will provide protection against infection with HPV types that they have not yet acquired. Sadly, the HPV vaccination rates in our country are not great. This data is a few years old, but as you can see here, only 6 out of 10 girls nationwide had started the HPV vaccine series in 2016, and 5 out of 10 boys. So why are these rates so low? Johns Hopkins had done a study and found that safety, lack of necessity, and lack of knowledge were the top reasons cited by parents. Vaccination rates, fortunately though, are slowly improving as parents and patients are being properly educated. So I'll end with this. Let's all remember that cervical cancer is preventable with vaccination, proper screening, and follow-up. Patient education is really key. I urge you to discuss the importance of the Gardasil vaccine with your patients and discuss importance of follow-up with patients, especially those who have abnormal pap smears and or dysplasia. For physicians who are screening and managing dysplasia, the ASCCP has a wonderful app that you can download on your phone, and it provides very clear guidance on how to manage patients. And if you're unsure, you can always send the patient to us in GYN Oncology for consultation. Thank you very much, and I am happy to take any questions.
Thank you, Dr. Patankar. Thank you. Are there any questions? Yes, I see that Dr. Goldberg has his hand up.
Thank you very much, Doctor. That was terrific. Very interesting, especially some of the newer things that you guys are using for advanced cancers. But as a generalist, I have a question. Actually, it was brought up to me by a patient this week for people who have persistent HPV and low-grade lesions. A product that's, I guess, getting recently studied called Deflagen. I don't know if you've heard of it. It's a silicone-based gel that is used intravaginally, and it may have some applicability in improving people with early cytologic abnormalities. Have you heard of it? And do you know anything about the studies that's related to it, or is it just snake oil?
Thank you so much, Dr. Goldberg, for your question. I actually have not heard of it, and I'm really curious to look into this medication. It's called Deflagen?
Yes, it's called Deflagen, and there's an article in a National Library of Medicine, obviously from the NIH. It's from Europe, in Germany and Austria, and they've used it. I'm looking at the article right now, and I'm sure you'll be able to find it. It's if you just plug it in, Deflagyn. My other question is, do you recommend giving vaccines to people who already have HPV?
Yes, I absolutely do recommend giving the vaccine to people who already have HPV. It won't, it's a prophylactic vaccine, so it's not going to get rid of the HPV that they're already infected with, but it will certainly prevent them from acquiring the other types of HPV that are covered in the vaccine.
This is Dr. Stevenson. I'm sorry, I didn't raise my hand. Did someone else want to ask a question?
Oh, go ahead.
Okay, so I am also pro-vaccine, even for women that, have high-grade dysplasia already and have been treated. I think that we tend to see a lot of these folks with, HPV, right? And the way I counsel patients is that there's no cure for HPV, right? CIN1 is not a precancerous condition. But, I think that with these high grade lesions that these women keep coming back for excisional procedures or lasers or this or that, I've been vaccinating even like 70 and 80-year-olds and 50-year-olds with, who are divorced and have a new partner, whatever. So I'm pro vaccine, but I'm interested to see, what other people's practices are in my group. If this is something, there was a meta-analysis that was that came out a couple years ago looking at decreased risk of recurrence for high-grade lesions in women who are already affected. So something that we should probably think about and look at. That's all.
Yeah.
I'm pro vaccine. Everyone, even the 80-year-olds.
Absolutely, Ruth. And I think, you raise an important point. Like, I frequently will vaccinate, like, even though, the guidelines are vaccinate between the ages of 9 and 45, I will frequently vaccinate patients over that age who have dysplasia. And I think, I've noted that a lot of GYN oncologists, our community does vaccinate these patients because they're at very high risk.
Dr. Gerda?
Thanks. Just wanted to respond to Dr. Stevenson. I also agree with therapeutic role for vaccinations in patients who have dysplasia, especially persistent one or positive margins on excisional specimens. Those are the patients that have been shown to benefit from therapeutic vaccines. I also wanted to thank Dr. Patankar for this really, really comprehensive and thorough lecture. It's amazing that you were able to compile everything into this short talk. I wanted to just highlight that the studies that you presented, the newer studies on less invasive management of cervical cancer, specifically, simple hysterectomies, conizations for those small lesion cervical cancers. So do we even need to do lymph nodes for those patients? That's the question. Should the early stage cervical cancer patients, can they be managed by a general gynecologist? Can you comment a little bit about that?
Yeah, thanks, Dr. Gerda, for that great question. Those studies have all assessed, lymph node dissection as part of the procedure. So simple hysterectomy with pelvic lymph node dissection, as well as a cone biopsy with pelvic lymph node dissection to ensure that there's no metastatic disease to the lymph nodes. And even though, we get PET scans on patients, PET scans are not perfect. And so we can miss disease. I would say certainly, I think that these patients should be managed by GYN oncologists. Patients need to be counseled about all of their options, and also, know the risks and benefits of all of the procedures. And sometimes, patient may meet certain criteria, but, God forbid, depending on final pathology, if there's any additional risk factors, patients may potentially need adjuvant therapy. And so I think it's really important for GYN oncologists to continue to see these patients and counsel and determine even whether the patient is an appropriate candidate for for a simple hysterectomy or a colon biopsy.
All right. Well, thank you, Dr. Patankar. Thank you for that thorough review.
Thank you so much for having me. It was such a pleasure. And sorry about the video.
No, it's all good. All right. Well, everyone, thank you for your attention this morning and your questions. We're going to end it here, and I wish everyone a safe and successful day. Thank you.